Welcome to your deep dive. Today we are looking at this massive medical blind spot, and it might actually be hiding right inside your medicine cabinet.
Yeah, it's a completely baffling mystery, honestly. It frustrates countless patients
Mm-hmm.
and, shockingly, even their doctors.
Right. Because what if the pill that you take every single morning, to protect your heart or to calm your bladder, what if that is actually the exact reason you're experiencing severe painful intimacy issues?
It is a phenomenal question. I mean, we're looking at a classic off-target effect here.
An off-target effect.
Exactly, where a drug does its primary job perfectly well, but it just, creates collateral damage in a completely different physiological system.
Wow.
And the real tragedy is that the people suffering from this collateral damage, they almost never connect it back to their daily prescription.
Okay, let's unpack this. Our mission today is to investigate how very common everyday medications, specifically systemic beta blockers for high blood pressure and anticholinergics.
Right, the ones often prescribed for an overactive bladder.
Exactly. How those inadvertently cause severe vaginal dryness and just a massive reduction in secretion volumes.
Yeah.
And we have a really dense stack of sources today to help us figure this out. We're pulling from clinical pharmacology texts, the AUA and SUFU medical guidelines, the British Menopause Society, and several consumer healthcare databases.
So, to really get to the bottom of this,
Yeah.
we kind of have to throw out the idea that the human body operates in neat, isolated compartments.
Right, right. Like they aren't totally separate silos.
Exactly. You cannot treat the cardiovascular system or the urinary tract without impacting the surrounding geography. It's all connected.
It is.
So to understand how, like, a heart pill
Mhm.
stops vaginal lubrication, we first have to look at the surprising mechanics of how that moisture is actually produced in the first place.
I'm so glad you brought that up because reading through these clinical texts, I realized my entire mental model of how this works was totally wrong.
Oh.
Yeah. I always pictured lubrication as this purely glandular function, like salivary glands producing saliva or sweat glands producing sweat.
A lot of people think that, yeah.
But that is missing the main event entirely, right?
And it really is.
Yeah.
So the baseline state of the vagina, that relies heavily on estrogen. Estrogen maintains the tissue thickness and the elasticity,
Okay.
and it supports the vaginal microbiome. It essentially keeps the local lactobacilli bacteria fed, which in turn produce lactic acid.
And that's what keeps the environment at that healthy, slightly acidic pH, right?
Yeah.
Below 5.
You got it. But what you were talking about is the arousal state,
Mm-hmm.
and that operates on a completely different mechanical principle.
Yes, the clinical term in our sources was genital vasocongestion.
Right.
And the mechanism just blew my mind. The blood flow to the pelvic region increases dramatically, right?
Yeah.
And it floods this subepithelial vascular bed.
Yeah, it's essentially this massive network of tiny blood vessels just beneath the surface of the vaginal lining.
Think of it like a sponge that suddenly gets completely flooded with water.
That's a great analogy. Because when that arousal occurs, those capillaries pack with blood, and the pressure inside them spikes.
Okay, so the pressure goes up.
Right. And this rising hydrostatic pressure, it acts like a physical press.
Mm-hmm.
It forces blood plasma, the clear liquid component of your blood, it forces it to passively transport out of the vessels and through the intraepithelial spaces.
Wait, really? So the body is literally using blood pressure to squeeze plasma through microscopic channels in the tissue.
Exactly. It's just pushing it right out onto the surface.
It is wild.
It forms what's called a transudate. So you get these tiny droplets appearing on the vaginal wall, and they eventually coalesce into a continuous film.
Like a plasma sweat, almost?
Basically, yeah. I mean, you do have some secondary moisture coming from the Bartholin's glands at the vaginal entrance.
Sure.
But the bulk of the lubrication is this plasma transudate, which is driven by intense localized blood flow.
This feels like a huge light bulb moment for understanding these drug side effects.
Oh, absolutely.
Because if the primary engine of lubrication is literally blood plasma being pushed out of engorged blood vessels by hydrostatic pressure, doesn't that mean anything that messes with blood flow or the nerve signals orchestrating that flow is going to completely derail the entire process?
That is exactly right. That is the biological vulnerability we're dealing with here. And it perfectly explains why our first major class of medications, the anticholinergics, cause such profound drying effects.
They go straight for the nerve signals.
They do. They cut the communication.
So I want to look really closely at these anticholinergics because according to the medical databases, these are incredibly common.
Very common.
They're prescribed heavily for overactive bladder, or OAB, with drugs like oxybutynin, sulfonylurea, and tolterodine. And we also see them in strong antihistamines and certain antidepressants.
Right.
But I struggle to see why a medication designed to stop a bladder muscle from spasming would shut down vaginal secretions. Those seem like completely different directives.
Well, what's fascinating here is how indiscriminate the parasympathetic nervous system can be.
Okay, the parasympathetic system.
Yeah, that network manages your rest and digest responses.
Right.
So it lowers your heart rate, handles digestion, and it is the master controller for stimulating bodily secretions.
They're all secretions.
Pretty much. Saliva, tears, airway mucus, and crucially, the vasocongestion involved in sexual arousal.
Wow, okay.
And the primary neurotransmitter driving all of those actions is acetylcholine.
Acetylcholine, so that's the biochemical key that turns on the fluid system.
Yes, exactly. And anticholinergics, by definition, they are muscarinic receptor antagonists.
Okay, break that down for me.
They actively seek out the M2 and M3 receptors in your body, and they just block acetylcholine from binding to them.
Oh, I see.
So when you take a pill like oxybutynin for an overactive bladder, the drug doesn't know it's only supposed to calm the detrusor muscle in your urinary tract.
It's not that smart.
Right. It travels systemically,
No.
blocking acetylcholine wherever it finds those specific receptors.
It's basically like turning off the main water valve to your entire house just because you want to fix a leaky faucet in the guest bathroom.
That is exactly what it's doing.
Like, sure, the sink stops leaking, which is fantastic for your overactive bladder, but now you can't run the dishwasher, you can't take a shower, you can't wash your hands.
Yeah, the medication just blunts the signal everywhere. So that drying out effect, it hits the mouth, the eyes, and the vagina indiscriminately.
Man, the crossfire there is intense.
Especially in the pelvis. You have to remember, the bladder and the vaginal tissues, they share a very similar embryonic origin
Oh, interesting.
and a similar pelvic nerve supply. Because the bladder is densely packed with those M2 and M3 receptors, the nearby vaginal tissues, which also rely on that parasympathetic nerve signaling, they are heavily impacted.
So the signal to initiate the vasocongestion is just simply muted.
Exactly. It never even gets through.
So anticholinergics turn off the electrical signal requesting the fluid. But our sources highlight a second class of medications that approaches the sabotage from a completely different angle.
Yes.
Let's look at blood pressure medications. Specifically, systemic beta blockers and diuretics, because these interfere with the actual physical delivery system of the moisture.
Right, the blood flow itself. So beta blockers are a cornerstone treatment for hypertension, arrhythmias, and, sometimes even anxiety.
Yeah, very common.
And they work by blocking beta-adrenergic receptors, which blunts the effects of stress hormones like adrenaline and noradrenaline.
Here's where it gets really interesting, because when we talk about lowering blood pressure, we usually frame it as a purely positive thing.
Of course.
Taking the stress off the cardiovascular system, slowing the heart rate, reducing the cardiac output. But the clinical texts outline a major sexual trade-off here.
Yeah, there's a big trade-off.
Because the physical stress response involved in arousal actively requires that cardiovascular jump, doesn't it?
It does. Sexual arousal relies on a robust, forceful rush of blood to the pelvis.
Right.
By systemically decreasing cardiac output and blunting that adrenaline response, beta blockers physically restrict that genital engorgement.
So you don't get the rush.
No. And without the sudden influx of blood, you don't get the hydrostatic pressure in those subepithelial capillaries.
The pressure we talked about earlier.
Exactly. And without that pressure, you literally cannot create the plasma transudate. You're effectively starving the lubrication mechanism of its raw material.
That makes total sense. I understand the heart pumping with less force. But the cardiovascular pharmacology sources mention something highly specific about vascular tone in the local blood vessels themselves.
Yes.
Can you walk me through the beta-2 adrenoceptors?
Yeah, that is a really crucial nuance. So beta blockers don't just affect the heart muscle, they actually affect the vascular pathways themselves.
The actual pipes, so to speak.
Exactly. Normally, beta-2 adrenoceptors provide this continuous, mild, vasodilating influence on your blood vessels.
Meaning they keep them relaxed.
Right, they help keep the vessels relaxed and open. But when a systemic beta blocker antagonizes those receptors, you remove that relaxing influence.
Which leaves the opposing force completely unopposed. The alpha adrenoceptors and alpha receptors are responsible for constricting blood vessels.
Precisely. You end up with unopposed alpha-adrenoceptor vasoconstriction. The local blood vessels in the pelvic region actually narrow.
Wow.
So not only is the heart pumping less blood to the area, but the pipes delivering the blood have physically shrunk. It is a dual mechanism of action restricting that pelvic blood flow.
That paints a very bleak picture for anyone relying on those vascular pathways for healthy sexual function.
It really does.
And it gets even more complicated when we bring in diuretics.
Oh, yeah, the water pills.
Right. These are frequently prescribed alongside or instead of beta blockers for hypertension, and
Right.
their job is to flush salt and excess fluid out of the body through urine.
Exactly.
So inherently lowering overall fluid volume is going to have a drying effect on mucosal tissues. But the texts revealed a secondary, almost hidden side effect of diuretics that absolutely floored me.
You're looking at the zinc depletion cascade.
Yes. I need us to dwell on this for a second because it is such a bizarre domino effect. Diuretics don't just flush water. They can actively deplete the body's zinc levels.
They do.
I never would have connected a water pill to a mineral deficiency that impacts sex hormones, but the sources map it out step by step.
It's a crazy chain reaction. So zinc is a foundational building block required for the body to synthesize testosterone.
Okay.
And while testosterone is typically framed as a male hormone, it is absolutely critical in the female body as well.
Right, people forget that.
They do. In female genital tissues, testosterone is converted intracellularly by an enzyme into estradiol.
And estradiol is a type of estrogen.
Exactly. It's a highly potent form of local estrogen.
Okay, so let me trace this. A patient takes a water pill to lower their blood pressure.
Right.
The pill flushes their fluids, which flushes out their zinc.
Yep.
The drop in zinc impairs their ability to produce testosterone.
Uh-huh.
Without the testosterone, the local cells can't synthesize the estradiol they need.
You got it.
And without that estrogen, the vaginal tissues begin to thin, lose elasticity, and stop supporting that healthy microbiome we talked about at the very beginning.
It is a profound biological chain reaction.
It's crazy.
And the clinical tragedy here is what happens when you look at the physical result of that chain reaction. Severe dryness, tissue thinning, loss of elasticity, irritation, and painful intercourse.
Which perfectly mimics the classic symptoms of menopause.
Exactly.
The AUSU guidelines and the British Menopause Society refer to this cluster of symptoms as genitourinary syndrome of menopause, or GSM.
Right. And that overlap in symptoms leads to a massive rate of misattribution.
I can imagine.
A patient goes to her doctor experiencing dyspareunia, painful sex, and decreased lubrication. Both the patient and the physician might look at her age and simply assume she's experiencing natural, unavoidable menopausal changes.
Just a normal part of getting older.
Right. The fact that her daily blood pressure pill or her overactive bladder medication is driving the severity of the symptoms completely flies under the radar.
It is silent suffering disguised as normal aging. I can only imagine the frustration of a patient trying all sorts of wellness remedies for aging, completely unaware that the culprit is sitting right there in their weekly pill organizer.
It's incredibly frustrating.
But, and this is important, our sources are flashing bright red warning signs on one specific point here. A patient listening to this should absolutely not just stop taking their cardiovascular or urological medication.
No, definitely not. Stopping beta blockers or blood pressure medications abruptly can trigger severe rebound hypertension, arrhythmias, or, worse.
Right.
The goal of understanding this pharmacology is to have an informed conversation with your prescribing doctor, because the guidelines clearly state that alternative drug classes exist.
Okay, like what?
For example, switching from a systemic beta blocker to an ACE inhibitor or an angiotensin receptor blocker, an ARB. Those can often maintain blood pressure control with significantly fewer sexual side effects.
So what does this all mean for the listener who might be dealing with this right now? Let's say a class switch isn't possible, or maybe the alternative medications just aren't working for their specific heart condition.
Yeah, that happens.
What are the practical, targeted solutions to counteract this chemically induced dryness?
Well, the British Menopause Society outlines a tiered approach, starting with non-hormonal management. And the crucial distinction here is understanding the difference between moisturizers and lubricants.
Oh, that's a good point.
Okay.
Because they serve completely different functions, yet people use the terms interchangeably all the time.
All the time. But a lubricant is strictly for the moment of sexual activity, just to temporarily reduce friction.
Right.
They could be water, silicone, or oil-based, though the guidelines do note that oil-based products will degrade latex condoms, so keep that in mind.
Good tip.
But a moisturizer is a maintenance therapy.
And the texts recommend moisturizers based on hyaluronic acid or polycarbophil polymers. Why those specifically?
Because they actually bind to the vaginal epithelium. You apply them regularly, say 2 to 4 times a week, completely independent of sexual activity.
Oh, okay. So it's not just for intimacy.
No, it's about restoring the baseline health of the tissue. The hyaluronic acid pulls water into the tissue matrix, actively rehydrating the cells and helping to drive the local pH back down to that protective acidic environment.
But if the tissue thinning and dryness are really severe, especially if that zinc testosterone cascade has depleted the local estrogen, non-hormonal options might not be enough, right?
Right. Sometimes you need more.
What I found fascinating in the guidelines is the pivot toward highly localized hormonal therapies, which kind of sidestep the fears a lot of patients have about old school systemic hormone replacement therapy.
Absolutely. The current gold standard for this specific issue is local vaginal estrogen.
Okay.
These are administered as ultra-low-dose tablets, like Vagifem, creams like Avastin, or even estrogen rings.
But why is that better?
Because the hormone is applied directly to the affected mucosa, it restores the cellular maturation and encourages local blood flow exactly where it is needed.
Yeah.
And the systemic absorption into the rest of the bloodstream is remarkably minimal.
So you aren't flooding your entire body with hormones just to fix a local tissue issue.
Exactly.
And there was another localized option highlighted in the sources that operates on a really novel mechanism, vaginal DHEA or prasterone.
Yes. Prasterone leverages a concept called endocrinology.
Endocrinology.
Right. DHEA is an inactive precursor hormone. So when you introduce it vaginally, the local epithelial cells take that precursor and convert it inside the cell into active estrogens and androgens.
It's like delivering the raw timber and steel to a local construction site and letting them build exactly what they need right there, rather than, shipping fully built houses across the entire country on a highway.
I love that. That's a perfect way to picture it. And the clinical benefit is that 95% of those active hormones are synthesized, utilized, and inactivated entirely within that local tissue.
Wow, 95%.
Yeah. It prevents almost any measurable increase in circulating hormone levels in the blood, which makes it an excellent option for patients who really need to avoid systemic hormone exposure.
That's incredible. Now, before we wrap up the solutions, I do want to circle back to the anticholinergics for a second.
Sure.
Because there's a very specific warning in the formularies regarding the anticholinergic cognitive burden scale, or ACB.
Right, the ACB scale.
We talked about how these drugs dry out the mucosa by blocking acetylcholine. But our sources emphasize that treating the side effects of an anticholinergic with another systemic drug can be incredibly dangerous for older adults.
It can be. The cumulative load is what the ACB scale measures. So every anticholinergic medication is scored from a 1 for mild up to a 3 for severe.
Okay.
Oxybutynin for the bladder is a 3. If a patient takes that, plus, say, an over-the-counter antihistamine for sleep, and maybe a tricyclic antidepressant, they are stacking a massive anticholinergic burden.
And what actually happens in the body when that burden gets too high? Why is it so dangerous?
Because acetylcholine isn't just responsible for bodily secretions and bladder spasms.
Right.
In the brain, acetylcholine is a foundational neurotransmitter for memory, learning, and cognitive processing.
Oh, wow.
Yeah. When you systemically block it across the entire body, you are also crossing the blood-brain barrier and blocking it in the brain.
That sounds really bad.
It is. High ACB scores in older adults are directly linked to cognitive impairment, delirium, accelerated dementia symptoms, and even increased mortality.
Which completely validates the British Menopause Society's push for localized treatments.
Exactly.
If your bladder pill is drawing you out, you don't take another systemic pill to try and force moisture because you are just adding to that cognitive burden.
Right, you're just making the problem worse globally.
So instead, you use a localized hyaluronic moisturizer or a vaginal estrogen tablet to fix the specific tissue without adding any neurological risk.
It is all about precision. If one system is causing collateral damage, you use the most highly targeted intervention possible to repair it.
So let's bring all these threads together. We started with the jarring reality that managing your blood pressure or an overactive bladder can completely sabotage your sexual health.
Yeah.
And we explored how vaginal lubrication relies on two essential pathways: the parasympathetic nerve signals, driven by acetylcholine, to actually demand the fluid, and robust, forceful pelvic blood flow to physically push that blood plasma through the tissue.
And anticholinergics cut the electrical signal, halting the process before it can even begin.
Right.
Meanwhile, Systemic beta blockers and diuretics restrict the vascular pathways. They blunt the cardiovascular force. They constrict the local blood vessels, and they trigger mineral cascades like that zinc depletion that starve the tissues of the hormones they need to survive.
And because the resulting dryness, pain, and tissue damage look identical to genitourinary syndrome of menopause, countless patients accept the suffering as just a natural consequence of aging, completely unaware of the pharmacological warfare happening right in their medicine cabinet.
If we connect this to the bigger picture, investigating these drug mechanisms is really an exercise in medical empowerment.
Absolutely.
When you understand the physiological chain reactions happening inside your body, you no longer have to suffer in silence. You can walk into your doctor's office equipped to ask about alternative drug classes like ARBs, or advocate for targeted local therapies like DHEA and hyaluronic acid that won't increase your cognitive burden.
We spend so much time acting like the human body is a machine with isolated parts, but the plumbing and the wiring are deeply intertwined. Shutting off the main water valve to the house is always going to dry out the garden.
That's so true.
Which leaves you with a final thought to ponder. We live in an era of unprecedented medical advancement, right? Where we map the genome and design highly targeted biologic therapies.
Right.
Yet the complex vascular and neural pathways of female sexual function are still routinely treated as acceptable off-target casualties in cardiovascular and neurological drug development.
It's unfortunate.
If a daily pill side effect can completely dismantle such a vital, deeply ingrained physiological response, could the future of pharmacology involve designing drugs that are genuinely smart enough to calm a bladder or lower your blood pressure without ever crossing over into the pathways of your sexual health?
The pursuit of true precision medicine demands that we stop accepting collateral damage as inevitable.
Hopefully the drug developers are listening.